I'd like to welcome you to the American Psychiatric Nurses Association's Policy Forum. My name is Peggy Halter, and I'm the co-chair of the Institute for Mental Health Advocacy. During these policy forums, we will be bringing experts on board to share their knowledge and expertise and experiences in navigating policy as it pertains to psychiatric nursing and psychiatric care. Today, I have the privilege of introducing Sharon Katz, who will be presenting her knowledge about policy implications of integrated care. I'll give you a little background on Sharon. Sharon received a master's in child and adolescent psychiatric mental health nursing and a postmaster certificate as a family psychiatric mental health nurse from the University of Pennsylvania. Sharon holds a certificate in marriage and family therapy from the APNA Institute of Philadelphia. Sharon is a frequent presenter at APNA both at the state and national level. Most of her work focuses on integrated mental health models of practice, including mindful care, a new nursing model, and holistic approach to mental health care. Sharon is currently the owner of Collaborative Care, a multi-site and integrated mental health practice based in Abington, Pennsylvania. It was founded in 1995 to advance psychiatric nursing in integrated medical environments. Sharon has worked in primary care and dialysis practices as well as developed an outpatient clinical practice to provide supportive mental health services. Her current office now has 19 clinicians in 2 outpatient centers and 2 integrated offices. These offices are both family medicine and pediatric. She continues to manage a large clinical caseload that reflect chronic mental illness as well as medical comorbid conditions. I'd like to start off this policy forum just by asking Sharon to please describe the background of her interest in working in an integrated care setting. Sharon?
Thank you, Peggy, and thank you, APNA, for this privilege. Integrated mental health dates back many, many years, like 50 years, and I became very involved at the very beginning of a project that was based out of U.S. Healthcare, in which I was an integrated member of the team that was overseeing integrated clinicians, and I was working for a outpatient clinical practice. And after I went through the orientation process and the first about a year of that program, I left that program and then decided to move into doing it my way, basically focusing on the psychiatric nursing roles. But I've been following it for a very long time, being in various different conferences and understanding what models of care that are being offered in the communities throughout the country and what demonstration models are being done in cities. And the information has been dramatic, and I'm glad to see that it's progressed to this point. For many years, I found that I had to make a list of obstacles to why I can't do it, why I can't, as a commercial provider of mental health services and as a psychiatric nurse, advanced practice nurse, why I could not actually open up my own integrated mental health group in a primary care practice. And I would make lists year after year, and then each year we would be able to say, okay, legislation, various things I could cross off, and we would be able to then work on those things. Or I'd ask my professionals that I know, my colleagues, my mentors, what they thought approach would be, and that's how we progressed it to this point. The Institute of Medicine created a funded project that wanted to investigate the future of nursing, and this was an integral part to make major changes in policy formation. The integration of mental health is also very important in this document, and it really illustrated in this document how we needed to bring future opportunities to allow us to expand in utilization. The recommendations of this document focus on the scope of practice barriers for RNs and APRNs, and this would give us the opportunity to address how psychiatric mental health needs to be expanded in the community mental health centers and the community health centers and the patient-centered medical homes. We need to be able to illustrate our scope of practice, and the Future of Nursing document really focused on the barriers that we have at this point to producing best quality mental health care available. The second recommendation was to expand leadership of nurses in medical teams through collaboration and care coordination. This is essential for us to have a calling in the patient-centered medical home because primary care providers do not have a lot of time to really lead the teams or partner with us in the teams. So this gives us a role that's very significant. The next recommendation was to implement nursing residencies to expand basic education and provide supervision during transition to professional roles. This was seen more in other clinical environments and clinical roles for other types of professionals, but this is something which we really could take seriously as well as a way to teach various different skills for the new graduates of APRN programs and RN programs so that they can function more in these patient-centered medical homes and the integrated models. Another recommendation of the Future of Nursing document was for health information technology to be used in integrated healthcare settings. In integrated mental health, we absolutely need to have health information technology. This is the critical link between the medical and the psychiatric, allowing us to communicate appropriate information and not all information to the primary care team. The next recommendation was for roles of nurses to lead partnerships. And the way that I've interpreted this is that roles of psychiatric nurses to lead the partnership in primary care and develop roles with psychiatrists to demonstrate collaborative practice. And this is what I've used in my practice. Well, psychiatric advanced practice nurses do lead the teams. They do refer to the psychiatrist in my practice so that they can have a role in either collaborating with us or taking on patients that are more acute than what we feel comfortable in handling.
So in 2010, the Institute of Medicine's report came out, and at the same time, the Affordable Care Act was being rolled out by Barack Obama. What kind of influence did the Affordable Care Act have on what you were doing with integrated care?
Oh, it was tremendous. We were waiting for this for years. The recommendations from the National Council of Community Behavioral Health and other organizations had been working on the patient-centered medical home and integrated mental health models for 30 years. We needed to be able to have a voice in healthcare, and through these documents and these models, we were able to produce it, and we were able to show cost savings. By putting it into legislation, and the Affordability Care Act specifically went into pages of discussion about primary care and how primary care is poorly reimbursed. And the primary care doctors had very little incentive. They were just working their feet off and trying to keep up with the demand and the needs. And they were dealing with a lot of psychiatric care in their practice settings. And there was dramatic data that illustrated that it was not cost effective the way that our old model was being proposed. So the ACA actually transformed primary care with incentives to demonstrate integration and collaborative care. And they chose the patient-centered medical home model, which is one of the models that was proposed, because the NCQA actually worked with that, and I'll talk about that a little bit later. But prior to the ACA, we did not have a voice. And no matter how much data came out, we could not change the system because the reimbursement system was deeply aligned to traditional reimbursement for illness, not preventative care, not for early identification, not for treatment. And it separated mental health from primary care. And it had a silo system of reimbursement. And that's slowly changing. So we're seeing that. The current healthcare system, as I said, was built on episodic care. And it failed to meet the need for prevention and earlier intervention of chronic medical and mental health disorders. The ACA also focuses us now on patient-centered care and comprehensive care and coordination of care addressing shortages to accessing care. So the patient actually is more involved. The primary care team is more diverse and allowed us to collaborate and actually gave us incentives, money incentives, to do that collaboration in the primary care setting. Unfortunately, at this point, the ACA reimburses and the NCQA, the National Council of Quality Assurance, reimburses only to the primary care medical homes, not to the mental health providers at a higher amount. So that is still an obstacle. The patient-centered medical home model, which I've referred to, actually is a little bit different, and it's very physician-focused. Okay, so when it says physician, they wanted to make sure that physicians are still the head of the team, even if they, it could be a nurse at the head of the team in a clinic model, but they wanted to put physicians at the head of the team. And I don't know what the policy implications are going to be for that word, and that's something which we can address later. But the patient-centered medical home is one of the models of healthcare delivery. But as I mentioned, the National Council of Quality Assurance actually oversees an enhancement of primary care reimbursement. And they follow 7 general characteristics. And the first one is personal physician care. That means a doctor, or in this case a doctor, actually a patient knows that their doctor can be called upon and they will see the same doctor consistently. The second one is the physician directs the medical practice. And as I said, that's something which we can always discuss in the future. The third thing is the most important piece. It's oriented towards the whole person, which means the mental health is now included in the patient-centered medical home, which is why we've really been able to expand into it. The fourth point that they look at in the NCQA characteristics is the coordination and or the integration of the care. Is this care also then, is there feedback loop? Is there a way of giving it to a handoff? And what documentation do they have going back and forth? Do patients follow through with the recommendations? And how are they handling that? The fifth general characteristic is the high quality and safety in care. And this is basically evidence-based practice. They want to make sure that the primary care homes are actually using basic logarithms that allow us to track the best care and actually give the recommendations. And that's key to their quality measures that they have, and there's 75 quality measures, which we'll discuss next, in the HEDIS measures. And the sixth general characteristic is enhanced access to care. So the primary care medical home is rewarded for accessing mental health care, and that's key to this process. And the seventh is that payment supports the enhanced services. I've yet to see that, but it does for the physicians, and it does for the patient-centered medical home. It doesn't for the outside providers coming in as much as it does for the internal bonuses that the patient-centered medical home model actually gives the primary care practices. And they do support us, and they do provide us the office space and other services, even if a lot of them do charge rent. It is something which they have as an incentive in their services, and that does come back on us in that. As I mentioned, that HEDIS is the Healthcare Effectiveness Data Information Set, and this is also included in the patient-centered medical home as a very essential piece of measurement of the performance on the dimensions of care and service. And this is a lot more transparent about what we are looking at as reimbursement. And 90% of health plans use this HEDIS tool to give us reimbursement. And I said us, it's because in many ways this is the trend of the future. It is something that's going to be phased in over the next few years for mental health. It looks like it's very active at this point. And measures for primary care doctors are right now measured for their performance in certain benchmarks for psychiatric care. They are measured in terms of whether or not they provide depression monitoring, ADHD assessment and monitoring, follow-up after psychiatric hospitalization, diabetes screening for patients with schizophrenia, and adherence to atypical antipsychotics for schizophrenic patients. Now, I'm extremely excited about HEDIS in some ways because it actually opens the door for us to have an impact, have a discussion more often with the government regarding integration and how to get paid for it. And I think that by taking over some of these monitoring characteristics and developing our own, it shouldn't just be for atypical antipsychotics for schizophrenics, but for bipolar, early identification of bipolar illness, screening of adolescents for early signs and symptoms of psychiatric illness. I think that there's a lot of other measurements that we can actually instill that would put our worth back in the patient-centered medical home.
Absolutely. I think the measuring portion of what we do and finding out if indeed we are being effective in providing this primary care and integrated psychiatric care is essential to the future of what we're doing with integrated care.